Okay, now it's noon. We'll go ahead and get started. Dr. Fowler has no financial relationships that are relevant to this activity. And without further ado, I will introduce our presenter for today. Dr. Melanie Fowler is a board-certified orthodontist who has been in private practice for almost 20 years, with offices in Lafayette and New Iberia. She also serves as clinical associate professor in the Department of Orthodontics at the LSU School of Dentistry and manages the treatment of patients with orofacial anomalies. She is an active participant in many professional organizations, including serving as the 2019 president of the Louisiana Association of Orthodontists. Okay, I will now pass over control to Dr. Fowler to begin the presentation.
Thank you, Julia. Okay, y'all bear with me for a minute while I get this shared. And I am going to attempt. Julia, let me know. I'm going to try and use a presenter view on my end while you guys see the regular view. Are you seeing?
We are seeing the presenter view right now.
Okay, well, I looked it up and it wasn't working, so I'll just do it regular. Okay, very good. Is that everybody's good? Okay. Well, anyway, thank you guys so much for allowing me to take an hour of your valuable time. I know it's hard for me also in the middle of a busy day to sit down and do some continuing education, but this is definitely an honor for me. First time I'm speaking to physicians. And so you all may be wondering why, why I'm doing this. And the reason is right there. So that is my sister, Kelly. She's on this webinar. She's a pediatrician in Broussard, and we're very close and definitely talk all the time. And, you know, sometimes I bounce things off of her. And one day I was just frustrated because I had seen a patient who was an adult and wondered why they hadn't been seen, you know, by an orthodontist sooner. And so I called her and I said, you do know, right, that early orthodontic evaluations are important. And she said, well, yeah, I think so, but tell me more, you know? So I said, maybe this is something that would be interesting for your colleagues to listen to. So even if it's, you know, I'm just hoping that you take away something that can be helpful or at least is entertaining. So our objectives this morning are this afternoon are very simple. I just want you to be able to understand the importance of early orthodontic evaluations and the benefits of that. Give you some case studies so that you can kind of see the issues that I see on a daily basis that you can be able to identify in your own patients, and really so that you can feel comfortable you know, referring out to an orthodontist if you feel like there's something that needs to be looked at. So just to start out, you know, what is an orthodontic evaluation? It's done by an orthodontist. So of course there's general dentist, pediatric dentist, and the general dentist and the pediatric dentist are looking at things that are different than what an orthodontist is looking at. And so what I do when I see a new patient is, of course, medical history. Obviously, there are relevant things in their past that I need to know about. Their medications. We all know that dry mouth is a big issue for dental caries. And so it's important for me to know what they're taking as far as medications, habits, thumb sucking, pacifiers, all of these kinds of things are important, and family history. Genetics is huge when it comes to growth patterns and everything else, as you well know. I will take a look at that child. We take photographs. We can do a photographic scan. What I'm looking for is the timing of exfoliation of primary teeth, eruption of permanent teeth. I'm looking at their occlusal relationships, the bite, and of course the growth pattern of the maxilla and the mandible to the cranial base. We take 2 x-rays, a panoramic radiograph, which I'll show you in a minute, and a lateral cephalogram. I have the ability to take a cone beam CT. I do not do that on a regular basis. That is for very specific cases. And what you may or may not know, depending on if you've brought your own kid to an orthodontist in Louisiana, the Louisiana orthodontist, probably 99.9% of us do not charge for an initial consultation. So if you're feeling like even this child may or may not be able to afford what could be considered cosmetic treatment, know that we see children for free, really up until they would need any sort of treatment. And so I'm going to show you some cases where I didn't do any treatment at all, and it was free for that child and that family, but it saved them things later. So this is just an example of what we do in my office: extraoral photographs, intraoral photographs, the panoramic X-ray on the lower right, and the lateral SEP right there. Obviously, we're all very concerned about radiation exposure, and so I wanted to throw in some information on that. Dental imaging is a very small percentage of of medical imaging in general. It's less than 1%, and so that's a good thing, and that includes orthodontics. A pediatric panoramic radiograph that I take, that I showed you, is 22 microsieverts, and if you compare that to New York to LA, that's 40, or a mammogram is 400. So it's a very, very small amount, an effective dose of radiation. And so I feel very comfortable taking, screening radiograph on my patients. All dentists and orthodontists are very aware of the Image Gently campaign, which just means responsible use of imaging. We don't want to take X-rays, every week on these patients. We use these sparingly. And then, in case you hadn't heard, the American Dental Association just recently this year discontinued the recommendation for thyroid shielding, mostly because it kept getting in the way, and so then they would retake, and that's not a good idea. So take it once and take it right. So that's the concept of that. And so let's talk about the ideal age. So the American Association of Orthodontists has always recommended age 7. The age 7 is when we will see the most benefit of an evaluation and potentially some early intervention. Why age 7? Age 7 is the perfect age when we're in the mixed dentition. And what that means, of course, is that we have a mix of baby teeth and a mix of permanent teeth. We start seeing around age 7 is when the transverse dimension of the mandible is nearing completion. And so we're starting to see what that arch form is looking like. And if I'm being completely honest, one of the main reasons 7 is a good age is because they will cooperate for me. They will be able to take pictures. They can listen to instructions. And it is the age where if I need to intervene with something, I can. I've seen kids younger than 7, and it's not fun. So 7 is just about right. They like coming to see me, and they're not scared at that point. So the common orthodontic issues that I'm going to talk about in a little bit include these. Obviously, there are more, but these are the most common ones that I see daily. Cross bites, whether that's anteriorly, posteriorly, arch length discrepancy, which is crowding or extra spacing, anterior posterior discrepancy, overbites or underbites, that's what patients call that, missing teeth, extra teeth, ectopic eruption of teeth, and of course asymmetry, whether that's with the bite or with the midlines. So this little one came in, and this is basically exactly what you can see when the child smiles at you, right? And so immediately we see we're in mixed dentition. We have permanent teeth, we have baby teeth, and we also see some of those common orthodontic issues. Anterior crossbite, we have some over-retained primary teeth, which is causing some ectopic eruption of those premolars. We've got a considerable amount of crowding in there. And so just in one little smile, that child, you can tell that something's going on in there that needs to be looked at. So if we don't see kids early, there's some consequences. And so we can see impaction of permanent teeth. Basically, the permanent teeth don't have room or come in the wrong place. Gingival recession, fractured teeth, temporomandibular joint disorders, TMD. Sometimes patients call that TMJ. Obviously, we all have two TMJs, but the disorders are what we're talking about. Bone loss, loss of teeth, and one that's really not talked about as much as it probably should be is a psychosocial dysfunction, depression, anxiety. This study was 2012 in the Journal of Pediatrics. Thank you, pediatricians, for doing this kind of research. And it's a large study. I mean, 40,000 children talking about dental problems related to school performance. And dental problems were significantly associated with poor work in school, associated with unhappiness, feeling of worthlessness, reduced friendliness. And of course, the largest component of that is between 15 and 17 years old. Now, we know that this is not the only reason that these children were having these psychosocial issues or school performance issues, but it is a component. And I talk to kids every day who don't want to smile, who are embarrassed. And it's in addition to other things that maybe are going on at home or other things that are happening. And so it's certainly a component. I wouldn't say it's not the only thing. And you guys know that, of course. So benefits. The earlier I see them, the earlier I get to them, the easier I can correct the issues, which means that it's going to be more cost effective, less time, less risk. It can prevent more serious issues. And of course, the improved self-esteem and confidence that we see in kids. So as a pediatrician, you are seeing these kids hopefully every year for their well checkups, and you're able, I know you all are looking in their mouth and making sure they're getting to a dentist and getting seen for their dental health. But it can be helpful for you guys to say, oh, I see a crossbite in there. That's something that an orthodontist needs to look at. And it's okay for these parents to know, because it's a different referral pattern. I get patients from dentists, from friends of patients, from families, from the internet. We have a different referral pattern in dentistry than in medicine. I do not have to have a referral from a primary care provider in order for insurance to cover. It's not how dental insurance works. And so I can get patients just because I put out on my Facebook, you should see your orthodontist, at age 7. So it's good that I'm able to get those patients and it doesn't have an effect on their insurance coverage. Speaking of insurance and cost, the typical cost for comprehensive orthodontics, and this is in the state of Louisiana, is somewhere between $5,000 and $10,000. Early treatment, though, when I see kids in mixed dentition, can be much, much less. And so much more affordable for families to be able to do things early. And so now for the fun stuff, the case studies are really where I like to, when I'm doing CE, I really want to see the pictures and the X-rays. So we're going to go through some cases, and I hope you enjoy it. So the first case, she comes in and her chief concern is that she has a diastema, or a gap between her two front teeth. And once I evaluated her, it was much more than just a space between her two front teeth. We have diagnosis of anterior and posterior crossbites with an occlusal shift. And so this is little Julie, and she's 7.5, and she comes in and mom says, yeah, we're here because we want to close the gap. I said, well, I'm glad you're here. I can close the gap. But the bigger picture is that we have a crossbite on this left side and a midline asymmetry. And so if you look at her face, especially when she smiles, her chin deviates over to the left. And that's because her upper jaw is too narrow. As she comes to close down, it is not comfortable. So her lower jaw slides over to the left into this crossbite. And so her entire upper jaw is too narrow. So what do we do about that? recommend a palate expander with some early set of braces. And so by age 11, this is just with early treatment, no treatment on the bottom at all. And this little one, she could have gone just like this into the world and not had any further treatment. So much less expensive. They chose to go ahead with finishing the lower. And so by age 13, she's completely finished. She's going to high school with no braces on, and she's really happy. And so, we don't see quite as much of that deviation, maybe still a little bit, but not, we have symmetry in the bite and symmetry for the most part. This next little girl I just saw her this summer, so I don't have any progress photos or x-rays, but she's almost 12 years old, very, very similar to Julie in the fact that she has this same issue with a constricted maxilla and this lateral shift on the left. Now, this is going to be a lot more difficult. This is going to be palate expansion. This is going to be full braces, top and bottom. And I'm hoping that I can get some symmetry in her bite. You can also see she's already started a little bit more of anterior mandibular growth, and that's tricky. She's as she's probably just probably not premenarchal still. She's probably already started her cycles, but her growth is where it's getting a little bit trickier for me to treat her. So this is one of those cases where I wanted to show, the difference between how early treatment can really be effective. And then when I see somebody too late, it can be a lot more tricky. Another case where they came in and they said, yeah, I have too much space. I have a gap between my front teeth. And what they really had was severe crowding. And so you can see that there's hidden issues. And so I start with x-rays on this case study just because you can be able to see it really well. So they came in because they said they had too much space. And so they're really focusing on the space between the two front teeth. But if you notice the upper laterals are completely blocked out. We have 3 baby teeth here and 4 permanent teeth that need to come into that space. It's a lot of crowding, and definitely in Dylan's case, this is going to be so much crowding that we can't fit all the permanent teeth in. And so that's a big hot topic in orthodontics, whether we take teeth out or don't take teeth out. But in Dylan's case, there was really no other option. So he was young. We recommended some baby teeth removal. So I send that back to the pediatric dentist for them to extract. I refer that back to them. And you can already start to see the premolars coming in, seeing a little bit of crowding on the lower. And then so the next step is this is called a serial extraction. And so the next step is to take out premolars. And so now we've removed the upper first premolars, and there's plenty of space. There's still been no orthodontic treatment. This is all just me following them and recommending extractions at the perfect time. So now it's time to extract on the lower. And so now he's missing all 4 first premolars and no crowding anymore, a little bit of space left over. Well, I've got you on this x-ray, bless his heart. He bumped his front teeth and needed a root canal. Root canal therapy does not affect orthodontics at all. We see trauma all the time. It can make the tooth more likely for root resorption and other things, but definitely doesn't affect orthodontic movement. And so this is him intraorally compared to when I first saw him at age 7. No room for the laterals or any of the other teeth. And then this is him right before starting a very short phase of orthodontics, premolars extracted, and there's that tooth that had the trauma. But you can see, even if we didn't do any orthodontics at all, this kid is going to be in a much better shape than if we did nothing. here, and he would have had ectopic eruption and other things probably, that we don't want to see. This is him on the lower, same thing. You can see the severe amount of crowding. These teeth are coming in way too far lingually. And then this is him with some self-correction, no orthodontics, premolars extracted. And so I just started him to finish him up. So it should be 9 to 12 months, and braces much more effective than the alternative. This is the third one. They came in, the chief concern was my teeth are short and I have a tooth that's not coming in the right place. The diagnosis was, again, an anterior posterior crossbite and moderate crowding. And so, she was worried because her teeth look short. Well, her teeth aren't short. Her teeth, that's the gum tissue issue, and so, and then we have an incisor coming in the back, but she's in a complete posterior crossbite on the right side, and she's, an anterior crossbite here. And that's a lot going on. She's 8.5. So this is better timing. And so I can do palate expansion and some early set of braces, a very short round, just to get her in a better occlusal relationship. I threw in her palate expander. This is just one type of palate expander. I use different types depending on the case. This one's called a quad helix, and that's because there's four helices. You may have seen some patients in your office with palatal expansion with little appliances that the patients or the parents turn. This one is, they don't have to turn on their own. It's all within the loops that I control that expansion myself. And so this is the patient at 13. And you can see with that palate expansion, how much room we made. All the teeth are going to have room to come in. We now have positive overbite and overjet, and instead of an edge-to-edge relationship, much more balanced in her lip position. And so we did a very short round of braces, and there she is. Now she has waited a little bit longer. She was 16, but she was really happy once we got them off. She'd go to homecoming. Well, I guess she was post homecoming on that, but that's what all my patients want, is braces off before homecoming. Our fourth case, they came in because of the upper right canine, but no one had told them that she was missing teeth. And so we can see in there, she was worried about that upper right side. She's got a baby tooth left over that shouldn't be there. She's got another baby tooth left over, and she's missing a tooth in between here. And, she's 10 years old. At 7, I would have been able to say, you're missing a tooth. We need to get these baby teeth out and get this treatment started so that she wouldn't have to deal with this at 10 years old. So you can see this is her initial pan. We have a peg lateral. That's what that's called when it's a little narrow lateral. Baby tooth over retain, and the missing lateral incisor right here. So we got the extractions done, and you can already start to see how things are starting to improve, even just by getting the teeth taken out. And that's what that looks like with the teeth out. And then there's things that we can do. We can actually do substitution. So these are not fake teeth. What we did with the braces is closed all of that space, and so reshaped these guys right here. And so she has no need for implants. She doesn't have to have, some sort of prosthetic or crowns or anything else like that. She's basically done. And yes, I can tell that those are not lateral incisors, and I'm sure you can too. But in a picture from far away, we've really made it so that, implant crown, which is about, at least right now, between $3,000 and $4,000 a piece. So we've saved her that, and she won't need any further treatment, as she goes into adulthood. So it's a good thing. Our fifth case is a severe one, and I threw this one in because it's one of those things that is a little bit more rare, but it shows what we can do and how we can help. This child had a severe tongue thrust, and y'all are looking for and referring to speech, I'm sure, all the time. This little one did not have that opportunity, and so by the time that I got to her, she was already, past due for speech. A real severe skeletal discrepancy, and then she had something really interesting that I'll show you on her X-ray. So you can see open bite, obviously excess spacing, and posterior cross bites on both sides. And she's 9. I would have loved to have seen her at 7 because I would have been able to tell this family, okay, let's get you to the speech. Let's start talking about some palatal expansion and different things. That was not what happened with her. She also had something super rare, which is called a transposition. So this is her second premolar, first premolar, and canine, the canine in between the premolars. And so if we can try to get these teeth to flip-flop, but most of the time that really doesn't happen. And so we have to compromise and put teeth in the opposite place than they belong. So she had a lot going on. This was her initial ceph. You can just really appreciate the length of her mandible. Really, really too long for this age, as well as the midface deficiency on that maxilla. So then we started with some selective extractions. You can see the premolars starting to drop in, but really not going to happen with the canines, not going to be able to make that jump across. We just got her a little too late. This is her continuing to grow, maxilla not growing, mandible growing. And so then after a first early phase of braces to open the space, we've got the canines at least down into position. We didn't extract on her. We just left the transposition. And then it's a matter of watching her grow and getting her ready for surgery. Obviously, we can't do any sort of surgical procedure until she's finished growing, because we don't want to do a surgery and then they outgrow the surgical correction. So got her ready for surgery. This is her pre-surgery. You can see, and one of the things we're looking at on this ceph is cervical vertebrae maturation. It's a good way for us to determine, along with the oral surgeon, are they ready as far as growth? And obviously these look really mature. So that's a good sign. No more growth. And then this is how she finished. And so after upper and lower jaws, we got the bite closed down, and she's super happy. So it's pretty dramatic. And of course, that's why I put it in here. I mean, it's very dramatic, but it's definitely something that we see and something that needs to be treated. She couldn't chew. She couldn't hardly speak. And now she can do both extremely well. And she's off to college this year. So, all righty. So our 6th case is similar to Maisie, but different because I got to see this little guy sooner. He was also a severe class 3 or underbite maxillary deficient case. You can see the difference being that he is more of a brachycephalic versus a vertical grower. So, and he was younger. So I can do things. The treatment that we used with him was the palate expansion with a protraction headgear. So it's a face mask headgear that connects here, and it helps bring the maxilla forward. If we have a good compliant kid, then they can do wonders with their maxilla. So this was him pre-treatment with that underbite situation, a little bit of maxillary deficiency. And then this is him at 10 post-treatment, positive overbite and overjet, and he wasn't biting down all the way, but you can really appreciate the difference between, you know, his underbite here pre-treatment and his overbite here. So this is why I want to see him early. This is why I want to, you know, be able to check on them and see if there's intervention, because now I don't believe that he will need surgery at all. He will be a you know, relatively simple orthodontic case. Our seventh case is the chief concern that the baby teeth won't fall out. And of course, he was diagnosed with severely over-retained teeth, which caused ectopic eruption of the permanent teeth. When you have a 13-year-old who has 11 baby teeth left, that's not normal. And, you know, of course, eventually would these teeth fall out on their own? Maybe, but the bigger picture, of course, is that that he's not brushing well, because this does not feel good, and the plaque retention around these baby teeth is extreme. You can see the redness in the gum tissue. He's probably had cavities on these brand new erupting teeth. So it's really important that and he was being seen by a dentist, you know, and so it's frustrating, of course, to say, okay, at 13 years old, we should know that we should have maybe 1 or 2, maybe 3 or 4, but not 11. So this was his original x-ray. He was a little bit delayed. 12-year molars, which is a misnomer anyway, weren't in at 13. 12-year molars can be erupt anywhere between age 9. I've seen it all the way up to 16. They're variable, but at 13, he shouldn't have this many baby teeth. And so this was him about 6 months after all the baby teeth were removed. And you can appreciate that, especially these second premolars, if the baby teeth had been removed on time, we would not have this zigzag in his arch form. The teeth would have come in the middle of the alveolus, and then, you know, he's not super crowded, so he may not have even needed orthodontics. And so that's when we finished him up at close to 16 years old. Still having a little bit of trouble brushing, I can see that, but at least no more baby teeth in there. And I have my last case. It came in for crooked teeth, and we realized it wasn't because they were crowded. It was because she had an extra tooth, and that was secondary to a cleft lip and palate. And so I see a lot of cleft lip kids. The good news in Louisiana is that Medicaid does cover for that. So Medicaid will cover their braces treatment if they have a cleft lip or palate, if they have any syndromes that have associated dental problems. So, you know, this kid obviously needed some treatment. She's got an extra tooth in there. And so you can see it right here. So, you know, that's not normal. And so this is when we finished her up. We took the tooth out, lined everything up, and, you know, made such a difference compared to, you know, having what looks like a big jumble in where the cleft was. And cleft kids have extra teeth. Cleft kids have missing teeth. And not one of them has the same issues. So I work with surgeons at LSU and Shreveport, the oral surgery department, as well as the Children's Hospital in New Orleans, because these kids, especially kids in this area, you know, tend to go to the cleft lip and palate teams there. We don't have a team here, and we used to, I think, but we send usually now. Y'all probably know that better than me. And then this is where she finished, and I use this x-ray just to remind you guys that you know, wisdom teeth are developing in 12-year-olds, and so, you know, you may not think that wisdom teeth are a thing until 16, you know, 17, 18, but they're actually starting to develop and can even erupt early. So they need to be looked at sooner than later, and not all the dentists are looking for that. You know, they're looking at cavities and other things. So, And so, I hope that these cases have been fun for you guys to look at, and that you can see that seeing kids early is helpful for them. It's going to benefit them in the long run. It's going to be easier for them, easier for the family. And just knowing a little bit about what I do, I hope will spur some thought in your own practices or with your own kids. And so I have, we'll open it up for some questions. These are my email address and cell phone number. Don't hesitate to reach out. I'm happy to answer any other questions.
I'm gonna switch over the share to the other side. Just to switch back, Dr. Fowler, if you'd like to drop your email address and phone number in the chat for people, that way they can grab that. And then if you have any questions, feel free to either put them in the chat or to unmute and share out loud. Yes, questions, comment, discussions, points, any of the above is allowed. Okay, Dr. Fulton. In Louisiana, there's a law requiring medical insurance to cover orthodontic treatment for children with clefting. There's a national law that's been drafted, but has not been passed yet, that would require medical insurance to cover orthodontics for any child born with craniofacial anomaly beyond clefting. If you're interested in learning more, or more importantly, advocating for it, please go to this link that Dr. Fulton has dropped in the chat.
Yeah,
Dr.
thank you so much for that. Yes, because it's huge, and I'm grateful in Louisiana that we can get it covered. Absolutely, a crossbite. So that is when the upper teeth fit on the inside of the lower teeth. And so if you can imagine, when you bite your teeth together, all of the upper teeth should fit over the bottom teeth. And so when an anterior crossbite is when that's happening in the front, where the lower teeth are on the outside of the upper teeth. In the posterior, that's upper molars, upper premolars on the inside. Why does it matter? It matters because for anterior crossbites, the way that the teeth are incising, the bone is not meant for that. If you have the lower teeth on the front side of the upper teeth, those lower teeth are going to continue to push towards the cortical plate, and you're going to have bone dehiscence, you're going to have recession, you're going to change how the teeth come together. And so that's the obviously issues with an anterior crossbite. In the back, the teeth are made to fit together and chew food and speak and everything else in a certain way. And so the enamel is thicker in the portions where you should have more chewing, more, if you're clenching or grinding or whatever. If you're in the wrong position, then you're going to be having enamel that's thinner, hitting enamel that's thinner. And so over time, your teeth are going to wear down more than they should. And so, when I see adults that come in and never had a crossbite corrected, where I'm seeing extreme wear on their teeth, I'm seeing potential fractures of their teeth, I'm seeing recession of the gums, bone loss. And so, a crossbite is certainly something that, we want to correct as early as possible. The reason we can use palate expansion in children is because, as you know, the mid-palatal suture does not close, just like other sutures. There is a point where those sutures are open. And so we can use that as, that in the palate, that until about age 14-ish in girls, maybe a little bit later in boys, that is not completely closed yet. And so when I say I use a palate expansion, I am not just pushing the teeth out, I am actually stretching that suture. And then after we do that, the bone fills in. And so And that's why we're all called orthodontists, but my, certification is in dentofacial orthopedics. And that's because we're actually changing bone position. And so on the mandible, there is no suture in the mandible, across the midline. And so we can't expand the mandible. So that's something we have to be careful of, is that, you can't overexpand the maxilla to match a narrow mandible. So I hope that answered your crossbite your crossbite question. What are the circumstances when wisdom teeth have to be extracted? Excellent question. I would say that no one ever has to get their wisdom teeth out. But the reason why it's recommended so often is because as we have, industrial revolution in our teeth, we're not losing teeth and everything else. We are keeping our teeth longer. Our teeth are the same size, but our jaws are smaller because we don't have to eat as much hard food, and we're not fracturing our teeth, we're not wearing our teeth. And so, whereas in long time ago, these wisdom teeth would kind of migrate in as you might lose a molar and you might, these teeth move to the midline. But now, because that's not happening, there's not a whole lot of room. The mandible grows backwards, but there's just not a lot of room there. And so if you have a situation where the wisdom tooth is either starting to impact, where it's coming in at a mesial angle, or it's stuck behind that second molar, the issue with that is all of the follicular cells that have created that wisdom tooth, those follicular cells build the tooth, and then as the tooth comes in, all of that follicular cells die. We don't need them anymore. They've built the tooth, and it's over. While that whole sac where the tooth is being formed doesn't go away. And so it's more a risk to have cysts or odontogenic tumors or other things like that can form, because these cells are not meant to last the whole lifetime. And so if we have patients who say, I absolutely do not want wisdom teeth out, then my answer to them is, that's okay. I get it. I understand it's scary, and you may not, whatever. But what I would recommend is that you're seeing a dentist every year who's x-raying and looking for hidden problems. There's also some, if you get bacteria back behind that second molar, you could get some bone loss, so you could lose that second molar. So for the most part, we just don't have room for them, and it's easier to get them out than deal with the consequences of leaving them in. Can you speak about the use of oral appliances in the treatment of obstructive sleep apnea? I've had some pediatricians ask me lately about the use of them from an online product, tooth pillow. Yes. So there's been a big push in dentistry in general for us as dentists to pay attention to sleep, to pay attention to breathing. This is our, area, so, but what has happened is that there's been a lot of, I think, overstep, meaning we are not trained to do sleep studies. We're not trained to read the results of a sleep study. We know this anatomy, but we are not the doctors who should be treating that. And that's my own personal opinion. But I feel like online, you're seeing these types of appliances be used because what's happening is they're using these appliances, and it's creating the jaw to come forward. It's positioning the jaw anteriorly, which, what does that do? It opens the airway, right? And it gives a little bit more ease for them to breathe. Well, that's great. Oxygen is great, but what it can do is it can also move the teeth. It can create temporomandibular issues, And so if a patient is severely retrognathic and has, and that is a reason or part of the reason why they are having some breathing issues, then we need to look at a surgical change, or we need to look at, something deeper than that. On a similar topic, there's a lot of orthodontists out there talking about, if we use palatal expansion, that's going to prevent sleep apnea in children. There's no research that proves that right now. There's a lot of research going on about that. I mean, the logic is there, and what I mean by that is, if we're expanding the palate skeletally, that's the base of, the nose. And so we should get more volume. That sounds great, but there's no research right now to prove that. Now, anecdotally, have I had children that I've used palate expansion on, and it has helped them. The parents are saying, well, now they are breathing better. Yes. Do I think, if I go into a situation and they orthodontically need palatal expansion and I do it and they happen to have better breathing, great, that is wonderful. But I can't tell my patients, or I don't feel comfortable telling my patients, I'm going to change the way you breathe by doing orthodontics. I can't say that right now. Maybe one day that there's going to be some proof to that. But right now, I have to stay on my wheelhouse, which is the orthodontics, and so we have to just be careful about it. I've gotten some referrals from some ENTs saying this child needs, can we try it? Because the next step is going to be, they're going to be on a CPAP, at this young age. And there's been some cases where when I look in there, yeah, they need it. They're in a crossbite, they have constriction and everything else. And so, the two probably go together, but it's not I can't solve problems by doing palate expansion. There are people out there clipping, lingual frenulums and all kinds of things, tongue ties. There's just not a lot of research out there yet, y'all, for that to be a thing. I'm a very much a science-based person. And as soon as, studies come out and say, all kids should have their tongue, clipped or whatever, because that's going to solve other problems. But right now it's just not out there.
Hi, Melanie. You're doing great. Thank you so much. I wanted to ask you a follow-up question to that. Kiddos that are having speech problems or feeding problems, are there clues in the early years? Because it's a very big thing for pediatricians to check in on speech and feeding, and that's just big questions that we are interested in the younger age group. Does any of that, is that a clue that we could pick up on that maybe we need to be prepared for orthodontic work?
Yeah, it's a great question. Absolutely. So, I mean, anytime there's a speech issue, especially lisping, it's probably associated, not always, but probably associated with, an open bite where the teeth don't come together. And so what's happening is their tongue is coming more forward and they're lisping and they're trying to, use their tongue to generate those sounds, and it's not working. And so, yes, so if you're hearing lisping, if you're hearing things, then what that means is that their teeth probably are not in the right place either. Now, chicken or the egg, is it because of the tongue position that their teeth are that way, or is it their teeth are that way and their tongue is going to that position? So, for example, babies with pacifiers, not a big deal at all. I'd rather a pacifier any day than a thumb. You can take a pacifier away, but you can't, the thumb, that's stuck with them. So But I mean, they can keep that pacifier a long time, even into 3 or 4 or 5 years old, without detrimental effects, you know. So obviously the younger the better, but if it's going to create an issue where the thumb comes in, give the pacifier back. But yes, if you are hearing speech issues, or they're having problems with eating, and it's their tongue, it might have to do with the position of their teeth. And so it doesn't hurt. It doesn't hurt for me to look at them, and if everything looks good, then maybe it is truly something that the speech therapist needs to look at. Or, you know, sometimes it can be a breathing issue or airway issue. You know, the tongue's going to come forward to get it out of the posterior part of the, you know, throat, and so to open it up. So but yeah, that's why I want to see them. That's why I want to see them at 7 or 8, because if we still have speech issues, something could be going on.
Okey doke, we have about 9 minutes left, so any couple more questions we can take, or just open up for discussion if anyone wants to come off mute and share a case or anything like that.
Well, it doesn't hurt my feelings if we finish early.
Yeah, we might give y'all back a few minutes, but I do want to give one last call for people to share or ask questions. This is the first time we've had an orthodontist on here, and hopefully we'll have Dr. Fowler back again, but we want to make sure that we have that opportunity before we close out.
Thank you very much. You know, you get nervous talking to people as smart as you guys. So I'm very, very grateful, and I'm grateful to all of you for being the real heroes in this scenario. So I hope y'all all enjoy the weather, and it's a good time of year. So.
Dr. Fowler, or Dr. Fulton, I added the contact information right at the bottom of the chat.
Thank you.
If we're filling in space, Melanie, both you and I had orthodontic experiences as children. That, I mean, you had a lot more work than I had to have. And I think your experience of it was so good that, you know, this was your career path that you chose. So, you know, for kiddos that are for, I guess, parents, maybe even pediatricians, I don't think it's as dangerous. Like sometimes there's this hesitation, like, oh, that's going to be so awful. The braces, that's they're not gonna be able to take care of them. It's gonna hurt. We're gonna have more problems than benefits from early treatment. You know, I've definitely heard parents like, it's too young. How are we gonna do that? How are they gonna cooperate? How is it gonna work? But I mean, at least for you and I and our children, it wasn't like that. Other than our personal experience, that the kids can't handle it, or that it's not tolerable. You know, braces hurt a little bit at the beginning, but it really, you get through that. And I think it doesn't matter if they're 7 or 17. Has that been your experience as well?
Oh, 100%. You know, the little ones do great. They are excited about it. They they like to come see me. They want to put colors on their braces. And really their alveolus is so flexible that, you know, the discomfort level in kids is way less than in adults. The adult patients are much harder to deal with, and usually not excited about it either. So yeah, the little ones, it is easy. And I never, you know, in orthodontics, this is not something that we hold kids down to do. I don't give them any anesthesia. I don't give them pain medicine. I don't carry a license to write pain medicine. because I don't need it, right? I mean, ibuprofen, Tylenol, that's enough. So it's easy, and I don't, if a kid truly will not cooperate, and I've had a few of those, we just don't do it. I don't believe in holding kids down for orthodontics. There was a question about retainers. Yes, absolutely. So retainers, unfortunately, back in the 90s, they did a huge research project and said, because prior to that, all orthodontists would say, you wear your retainers for 2 years after your braces, and then you can throw them away and your teeth are fine. And that's just not true. As we know, our bones never stop remodeling. We're genetically programmed to have teeth in certain places sometimes, retainers are for life. And that can be any kind of retainer. It can be a bonded retainer that stays in. It can be a removable retainer that you wear at nighttime. But I tell patients, this is your insurance policy. I've put your teeth in a beautiful position, great smile. And in order for you to keep it that way, we know that if you wear a retainer, your teeth will stay where I put them. If you throw that retainer away, then you're gambling. You're gambling with your result. And age, it just part of aging, our teeth change. We're wearing our teeth in different places. We're doing different things. So I am obviously a huge proponent of bonded retainers when I can, and a nighttime retainer to prevent from clenching, grinding. I see a lot of, especially teenage girls, wearing their teeth down because they're so stressed out from school and from life. And so if they wear a retainer every night, they're protecting their teeth. So for me, it's important that my patients leave the office with retainers, and that they know that they, if they lose it or their dog eats it or whatever, that they need to come back and see me. So yeah, unfortunately, there's some research going on right now about some sort of medication. I don't know if it's a direct or it's oral pill or something about like that would stop the tooth movement after braces. And I don't know how that would work. I have to do something with the osteoclast or something. I don't even know, but so people are interested in preserving orthodontic results even to that extreme.
Okay, well, we'll go ahead and go through the final little bit of announcements that I have and wrap it up. I already posted the evaluation and stuff in the chat, but I'm about to post it again just so it's on the bottom. But make sure that you take your evaluation. This is how I know that you are here and want credit for this activity. And it helps us continue to improve and claim your credit. Typically, our evaluations take less than 2 minutes to complete, so it shouldn't take you very much time at all, and helps us to continue to improve our CME offerings. And then our next webinar will be with Dr. Raj Warrior about Epstein-Barr virus, and that will be in 2 weeks on October 24th.